Good morning, everyone from Boston. Good afternoon to those of you who are in India, and welcome to this Lancet Citizens Commission webinar. This commission was commissioned by the Lancet in 2020. It's an ambitious cross-sectoral endeavor that involves a large group of commissioners and authors and research fellows working across India and the diaspora, that has conducted research and done a deep analysis of the healthcare situation in India, with the aim to lay out a citizen's roadmap to achieving universal health coverage for all the people of the country. The Commission's webinar series serves as a platform for public health discourse around some of these issues and a means for academics, practitioners, and the public to engage on some of the most critical, substantive recommendations that concern universal health coverage in India. And today's webinar focuses on one such critical recommendation. If you would like to stay engaged with the Commission, please sign up to receive the Commission newsletter, alerts for future webinars and events. You can do this through our website, www.citizenshealth.in. Now, I want to straight away introduce you to our moderator, Dr. Nachiket Moore, who is one of the commissioners. Dr. Moore is an economist whose current work is principally focused on the design of national and regional health systems. He's a visiting scientist at the Banyan Academy of Leadership and Mental Health and a visiting professor at the Indian School of Business. Nachiket, thank you so much for moderating and bringing this panel together. It's an incredible panel, and I'm going to hand over to you now to introduce our panelists and to moderate this webinar.
Thank you very much, Vikram. It's a real pleasure to be here and to have the opportunity to engage with such a distinguished panel. I cannot imagine actually a better panel to discuss the core issue that we have today that we're going to talk about. Instead of spending the time right now to introduce every panel member, I'm going to take the liberty of introducing them just before they intervene with their remarks. And I will get us started on the conversation right away. The issue that we are here to discuss in the webinar has to do with the public sector worldwide, but certainly in India. And we know that certainly in the Indian context, the public sector has a vital role in delivering healthcare services. And it is the only full-service health system in the country, which goes from public health all the way to tertiary care. It's been built over many, many years. And we believe that it can be tasked with the responsibility of delivering universal health coverage entirely within the public sector to each and every Indian, both rich and poor. The research that we've done suggests that while there are significant gaps, given India's substantial advantages in producing human and other resources, we think that the current expenditures of the governments, state governments, while there are still gaps, could be adequate to actually finance universal coverage. The key challenge for the public sector, we believe, is not financing, but that of performance. That is to deliver good health outcomes, use the resources allocated to it efficiently, and be responsive to the needs of the people that it serves. One of the mechanisms that has evolved to meet this need, that the late Dr. Wagstaff referred to as an emerging consensus, to become the norm for the public sector in both developed and developing countries, is what is referred to as the purchaser-provider split. The idea here is that there is no automatic funding to government departments that have chosen to become entities that focus on the delivery of healthcare services, but that the money is instead given to an independent purchaser, and that the purchaser in turn pays the government health facilities based on some well-defined payment mechanisms, which there could be many such approaches which blend global budgets, capitation, fee-for-service, and such like. So this is one government entity receiving the money and paying another government entity on an arm's length basis based on some parameters. unlike the current line by line or line item based approaches, which are focused on very tightly controlling the supply of inputs, this reform, in whichever country it's been implemented, seeks to combine a higher degree of trust and autonomy given to the provider with greater accountability for outcomes. So it's a different way of thinking about the behavior of the public sector and the performance of the public sector. In the Indian context, if we were to think about this reform, a potential direction could be that the public sector could form integrated delivery entities, what we are referring to as integrated delivery systems, IDSs, which combine primary care and secondary care into units perhaps at the district level or the sub-district level, populations of somewhere between 500,000 to 2 million, with each IDS being paid by a state level purchaser on the basis of various payment mechanisms that we have. One potential direction could be that the purchasing authorities established in India under the Prime Minister's Jan Arogya Yojana, PMJY, which are called the National Health Authority at the national level and the state health authorities at the different state levels, they could be tasked to perform this function. Today, they use a small amount of money that is given to them by the state government and by the national government to buy a limited quantum of health services, hospital services from the private sector and the public sector. The thought would be to restrict their role to focus only on the public sector, no longer work to provide financing to the private sector, but instead of getting only a small amount of money that they're getting today, they get the entire health budget of the state government. And to move forward in this direction. Of course, there could be multiple stages. If indeed this direction we were to pursue, there could be multiple stages that could be adopted. You wouldn't go big bang from where we are today to that approach. The salaries would continue for a while. There would be specific programs that are of priority, like tuberculosis, for example, would continue to receive dedicated funding in the old way. And initially, instead of building rigid payment mechanisms, funds could be transferred closer to where the action is, and to see if that capacity gets built. So this is the broad idea that we have in mind as an idea to think about for reforming the performance of the public sector. And our hope is that in today's discussion with this wonderful panel that we have, we will get into some of these questions. Is it, what has been the global experience? What do they think is the readiness of the Indian environment, or in the other countries that they have chosen to see this, that they have seen this happen? How well have these programs gone? And really, that's something that we want to learn from this discussion. I'm going to introduce each panelist as I request them to intervene and to share their thoughts with us, so that you have a sense of who each individual is. I'm going to start by inviting Dr. Inke Mathaur to share her thoughts with us. She's a senior health financing specialist at the World Health Organization. She leads the work on strategic purchasing for universal health coverage, with a particular focus on payment systems. She has, of course, many other roles and responsibilities, but from when we started to think about who the panelists would be, almost everybody we spoke to told us, you must try and persuade Dr. Mathaur to join this discussion, because there's nobody that has really understood and looked at these questions at the level of detail, as well as, from a perspective sense, than she has. Dr. Mathaur, may I invite you to share your thoughts with us to get the conversation going? Thank you.
Yeah, thank you so much. Can you hear me well?
Yes.
Yes. So good morning, good afternoon, and good evening. And thank you, Dr. Natiket, very much for this nice introduction. Thank you for inviting me to this wonderful panel. It's a great honor and pleasure to be here with you. Now, this is a really important topic, and I think it doesn't get as much attention as it should in the policy discussion. So I'm very happy that you actually take it up here specifically in this panel discussion. And I do look forward to the discussions with you, with the audience on this subject. So let me react to these ideas that you have just outlined. And in our previous or prep discussions, in fact, you had asked me to give an outline of the advantages or the assumed advantages of a purchase or provider split. And then based on that, I will look from a global perspective at the wide range of country arrangements that we find with a purchase or provider split. And indeed, there's a very wide practice, and we can learn a lot from that. So what are the expected benefits of a purchase or provider split? What is it? So let's think of this as an arrangement with in which a third-party payer is kept organizationally apart from service providers, as Dr. Natiket has been saying. I mean, it's really thinking about a contractual relationship between the purchaser and the providers. At best, it's an explicit contractual relationship, but of course, we also have situations where it's more sort of implicit. And we can also think of that as a principal-agent relationship, with the principal being the purchaser and the agents being the providers. And there are all kinds of issues around principal-agent relationships. I'm not really going into that, but it can be helpful to keep that in the back of our mind. Now, the real idea and objective of the purchaser provider split is that this contractual relationship, whether implicit or ideally explicit, allows to build in an incentive structure through payment methods in order to strengthen and improve quality and to improve efficient behavior of providers. And this separation of roles, splitting the provider from the purchaser allows for a specialization. And this split also then makes it easier to move away from sort of this rigid line item budget allocation logic and to introduce other payment methods, foremost ideally output-oriented payment methods. And so the underlying idea really is making purchasing more strategic. Maybe to say that upfront, the purchaser provider split is not per se the objective. It's a means, it's a policy instrument, so to say, but what we ultimately want is making purchasing more strategic so as to progress towards universal health coverage. We can think of more specific aims. It depends really on the country context and the country set up, the problems. Cost containment could be an issue, but that really depends on where the country is. What we also want to see is improved responsiveness of service providers to patient needs. It is assumed that a separate purchasing agency is able to be more explicit about, thinking through costs and sort of setting cost limits through the payment methods. And as such, ultimately, the idea is that one can better match health policy and health service priorities with the actual allocation of resources to the providers. I think Dr. Natiket had mentioned already the issue of increased accountability or responsiveness. That's in terms of the providers towards the purchaser, but also the purchaser upwards towards the agency, or I should say maybe the organization, the ministry to which it is attached. So normally the Ministry of Health, but not necessarily. Another idea is to create competition through a purchaser provider split, namely competition among providers between providers. Maybe I can just sort of mention that on the side, but this is something to carefully explore from various angles. In remote areas, in rural areas, are there enough providers, public providers, that could compete with each other? Is it politically actually opportune to have this competition if a contract is not given to each and every public provider that is actually operating in a specific catchment area? So it's about also ensuring that all people have access. So we have to think about political feasibility. We have to think about, context-specific decisions. Can it, would it operate with, would it function with a performance-related payments as well? So various things to consider about competition, but maybe we can take this up in the discussion. Of course, there are also downsides to purchaser provider splits. So it's not just all positive. There are also potentially some disadvantages or some things to consider. But I leave that to the next panelist because I think you go into more detail of some country examples, and so that will come up there. But now let me come to my second point, which is really about trying to give an overview of the country examples and the large spectrum of where a purchaser provider split is in place. And I'll focus on low and middle income countries. Now we can look at this from two angles. We can distinguish different types of financing schemes. So this is the arrangement through which health expenditure flows. So I'm using the systems of health accounts terminology, the financing scheme. Basically, we have two main ones. We have government schemes and we have social health insurance schemes. Of course, there are other scheme types, such as voluntary health insurance, but we're not talking, or I won't talk here about it. So government schemes and health insurance schemes. And these schemes, they can operate on very different institutional bases. So that's the financing agent, again, in SHA, in System of Health Accounts terminology, or many of you maybe may be more familiar with the term National Health Accounts framework. So the financing agent can come in various forms, can be a government unit, can be a department or unit within the Ministry of Health, can be a social security or a social health insurance agency, could be a commercial insurance company, corporations, semi-public agency, mutual, non-profit agencies, or trust model, etc. So there's a whole range of different types of institutional arrangement that we can think of underlying the purchaser agency in this purchaser provider split. But I think it's important to point out here up front that the more critical policy question is really on the type of the financing scheme to provide health coverage, rather than the question about the financing agent or this institutional arrangement. That will come sort of as a second question. Yeah, how do you organize the purchasing agency? Can be, there's some path dependency. It could be through some historical legacies, but there can also be very explicit political decisions and really change from one form to another. So let me now go a little bit deeper into the financing schemes and really sort of outline and link our discussion here on purchaser provider split with, what we have out there globally. Now, the classic example of a purchaser provider split, as we would maybe sort of immediately and intuitively relate to, is a national health insurance scheme or a social health insurance scheme. But I prefer to say national health insurance scheme, as we find it now in a lot of countries that have set up an integrated scheme for the whole population, not segmenting for different population groups or only the formal sector, but really for the whole population. So we have Indonesia, Philippines, Mongolia, Vietnam, Sudan, Ghana, Turkey. Or, Chile and Korea set up integrated schemes while there were still middle-income countries. Now, both being high-income countries, but they set this up when there were middle-income countries. And of course, we also have a number of countries with separate health insurance schemes. So schemes for formal sector employee, and then another scheme or several other schemes for other population groups, such as in Colombia or China, Rwanda, Kenya, until recently now with its new bill sort of making a transformation. But linking it to our discussion here in India, I think what we're really interested in is looking at purchaser provider splits found in government schemes. And in fact, there is a growing number of countries that allocate government funds to explicit government health coverage schemes. So it's an internal transfer, so to say, within the government funding. Often, but not always, these schemes, these explicit health coverage schemes are for selected population groups that are usually outside the formal sector. So it could be for the poor or other defined vulnerable population groups that have an entitlement to health services on a non-contributory basis. So they do not make health insurance payments, health insurance contributions. And so that's why these arrangements are classified as government schemes, even though, in fact, in a number of countries, one would perceive them, or they would even be called health insurance schemes or health insurance type schemes, because in fact, they show several institutional design features of health insurance. So let's look into that. And then I'll give some country examples. So the first institutional design feature obviously is to have a separate and an explicit purchasing agency, so as to have this purchaser provider split. But important, again, I come back again and again to this point, this in itself is not enough and cannot work on its own. We need other critical features, namely second, some form of empanelment of patients or of beneficiaries, or let's say involvement affiliation of population groups, be that explicit or be it through automatic participation, based on residence or citizenship. For example, in Thailand, everybody outside the formal sector is automatically part of the Thai universal coverage schemes, or can also be based on catchment areas in other countries. And then the third key element is to provide a clearly defined and explicit benefit package. And so when we have these three features, then that's really the basis to be able to move away from line item budgeting to another provider payment method, or ideally, at best, we have a mix of different provider payment methods so that we can use different incentives that sort of in a combined version really set the right incentives for providers to focus on efficiency and quality. So we have a number of middle income countries, for example, in Eastern Europe, Georgia, Latvia, Montenegro since 22, or Kazakhstan until the mid 2010, I think 2016, yeah, that channeled government revenues to a separate purchasing agency to finance health coverage for the whole population with access to a comprehensive benefit package. So no contributions are paid. It's fully tax funded, fully funded through government revenues. Then we have another group of countries that have set up a health coverage program with a purchaser provider split with these above features that I was just outlining, again, non-contributory. In the cases that I will outline, it's for defined population groups, not for the whole population, often those outside the formal sector. And even though there are differences in scale and scope of the benefits, they share these common features. So, you know, I can mention Cambodia's Health Equity Fund. Of course, PMJ in India is a government scheme from National Health Accounts terminology or classification. Pakistan's Sehat Sahulat program. And yes, of course, as I mentioned already, the Thai universal coverage scheme. Argentina has a SUMAR program. Again, it has a separate unit. Interesting, within the provincial government. So it's not completely outside, but it's organized as an autonomous management unit. And interest in terms of labeling, it's often referred to as provincial health insurance. We can also think of the free healthcare policies that we have in a number of African countries. Benin, for example, has a policy for free cesarean section. They have set up an agency separately as a unit within the Ministry of Health, but it is again being independent, and as it functions as a purchaser and pays the providers explicitly for the C-sections that they provide. So there's an explicit reimbursement mechanism. And that is important and to be seen in contrast to another group of countries where we may find some form of affiliation of defined vulnerable population groups, such as the poor, that get exempted from user fees. So they have a card and there has been a targeting processing, they have been identified, they have been enrolled. But in these countries, there isn't a purchaser provider split. And again, although that's not the main issue, the real issue is that because there is no purchaser provider split, there is no explicit reimbursement line set in practice, in place. So providers actually just continue operating on a line item budget logic. And so ultimately it means that people, despite having this card, they don't really get these explicit benefits as described. They may still have to buy the drugs elsewhere or buy for certain services or get the supplies from elsewhere. So what's really decisive is to have explicit payment of providers, not just line item budgeting, where first of all, providers don't really have much autonomy and discretion space, but also they don't have an explicit output-oriented or output-linked payment. And so all the countries that I was just mentioning, they have realized great achievements in terms of universal health coverage progress through a purchaser-provider split with explicit coverage, with explicit payment of providers. And that's really my take-home message. We have a very large and further growing number of countries with explicit health coverage schemes based on a purchase-provider split in government schemes. And so to progress towards universal health coverage, this can be indeed pursued within government schemes. Countries that seek to expand coverage should not think that only social health insurance is the only way to do this. I'm just mentioning this because we do still see these discussions sometimes in countries saying that, you know, we need a separate purchasing agency and we need social health insurance to progress towards universal health coverage. I think what matters is the institutional setup, having a separate purchasing agency and having, you know, explicit reimbursement of providers. Maybe just two other thoughts. One is on if I have still time. Do I still have 2 minutes?
Oh, you do, ma'am. Please,
Yeah?
you know, share with us
Yeah.
what you
Yeah.
have in mind.
Good. One other important question that you raised, Dr. Nachiket, is about, you know, only contracting or only providing these services through the public sector, through government health facilities. And that's a really important question, and that lots of countries, you know, are contemplating with or have taken a decision already. Is it public sector only or also private sector? We do have a number of country examples, actually more with a health insurance fund, not so much a government scheme as such, but the issues are the same. And we see in these country examples that more than 80% of the funds that go through this purchasing agency, they actually flow to the private sector providers because people have access to them. They prefer going there. And when there is no cost sharing or low cost sharing at the private sector providers, then obviously this is not a surprising development. The big issue is that it means that the public health facilities, they're completely losing out from that money that has been made available for, you know, for this to this purchasing agency, to the separate purchasing agency. So actually, they're really losing out on a lot of the resources, and they cannot make the necessary quality improvements. So therefore, it's very important to carefully think about, is it needed to include the private sector? And I think there are a number of caveats. You also hinted at the issue of what are the impacts of a purchaser-provider split. Obviously, what we want to see is progress towards the universal health coverage objectives, the intermediate ones, efficiency, equitable distribution of resources, accountability, and then also the final UHC goals, equitable access, financial protection, and quality. So this is the issue. It's hard to measure the effect of a purchaser-provider split itself, because in fact, it comes along with several other changes. It comes along, I mean, that's sort of the main rationale, moving away from line item budgeting towards a different provider payment mix to incentivize efficiency and quality, right? It comes along with some degree, it must come along with some degree of financial autonomy of the facilities so that they can respond to the financial incentives set by the provider payment method. And it comes along usually with a defined and explicit benefit package, as well as with, you know, a clearer, hopefully clearer, it's very hard, but hopefully with a clearer referral system that's being followed, if not to say enforced, and gatekeeping. And so that's why it's hard to sort of just disentangle the effect of the purchaser provider split itself. We have to actually assess the overall package. And I want to give one example of a country that has set up a purchaser-provider split, but hasn't done the other things. And what does that actually imply? This is the example of Egypt. And let's be very fair. Egypt has initiated a very ambitious and great reform, introducing a universal health insurance agency, being introduced in phases. It's a major transformation of the health system as such. So, you know, let's see this as part of the process. And this is really meant as sort of seeing, okay, what next? What are the next steps? So the Universal Health Insurance Agency was set up as the purchaser. And at the same time, another agency was set up, the Healthcare Organization, which is an umbrella organization for providers, which receives capitation payments from the Universal Health Insurance Agency. However, these payments, these capitation payments, are not then allocated to primary care providers along the capitation payment logic. They're still given in the form of line item budgets to primary care providers. And so while in fact institutionally there's a very strong purchaser provider split, that logic isn't really fully translated and coming through in the other elements. The other necessary elements aren't there. So providers continue operating under the incentive logic of, you know, relatively rigid line item budgets. And said through capitation payments, they cannot actually really come through. Maybe I'll stop at this point, and maybe in the discussion we can talk about the prerequisites of a separate purchasing agency to be set up. But I'll stop at this point. Thank you very much.
Thank you, Dr. Mathur, for such a comprehensive overview of a difficult and a complex topic. And it's really set us up very well to go deeper into some specific questions. Let me now turn to Dr. Rifat Atun, who is a professor of global health systems and the director of Health System Innovation Lab at Harvard University. His research focuses on health system performance, design, and innovation, and he has advised many governments on health systems reforms, the World Bank, the WHO, and even outside the government in the private sector. So I cannot imagine somebody better qualified to help us with this. Dr. Atun, you have experienced this transition across many contexts. In fact, my understanding is that some of the earliest ideas of purchaser provider split came from the UK and from the administration of Mrs. Thatcher. And you were involved in actually seeing this transition. You led a fund holding consortium as a purchaser. You were one of the early groups of leaders who were actively involved in innovative approaches to purchasing. Now you see, after 25, 30 years of this approach, the NHS England is returning, we believe, and it's something you would know much more about, to integrated health and social care models, something to understand as to what happened there. You were also involved quite closely in the transition in Turkey. And you know a great deal about how they went about thinking about this purchaser provider split, and how did they think about the government health system. My understanding is Turkey is very much like in India, a public sector finance, public sector run health system, which then, in a sense, in the middle of this overall mechanism, I'm not talking about a separate insurance scheme or a PMJY or a Phil Health type scheme, but they took their core government finance, government delivered healthcare system, and then set up this split with the hope of improving actually performance. Just share with us, Dr. Atun, in whichever way you think is appropriate over the next 5-10 minutes, as to what do you think are some of these experiences telling us, the UK experience, the Turkey experience, as well as the others that you would have understood and seen. Over to you.
Thank you, Nachiket, and thank you to the Commission for inviting me to contribute to this panel, and pleasure to be with the distinguished panelists and friends. I'll share with you, first of all, my experience as a purchaser in the UK. And this the purchaser provider split came as a surprise. There was an announcement by then Prime Minister, which caught the civil servants by surprise. They didn't know. So this major policy shift was announced. And I remember at the time speaking with one of the very senior civil servants, actually, the permanent secretary, I believe, at the time, and he commented that we were caught unaware. There was no preparation. There was this major policy shift that wasn't discussed or debated. So there was, so the UK was presented with the fait accompli, with a purchaser-provider split. But of course, the devil's in the detail. What does this actually mean? Well, that required a lot of effort, actually, because the country and the system, the national health system, was really not prepared for this shift. And I want to share with you some of the elements that need to be in place to transition to a purchaser-provider split. And this comes in different shapes and forms. First of all, one is the purchaser or series of purchasers, and one also needs providers who are going to be able to enter into agreements with purchasers to provide against an instrument like a contract or a service agreement, series of services. Now, but that is not easy, because one has to have a regulatory framework in place, especially in countries where markets do not exist, to define what is the nature of these entities, these purchasers. Are these independent insurance entities? Are these so-called quangos, quasi-autonomous non-government agencies. Again, there's a whole range of considerations in relation to the legal framing of these purchasers. And of course, with that, one has to consider governance, to ensure that this has to be inclusive, and one has to also consider accountability in relation to these entities, because they're managing public funds, and there will be regulations in relation to whom they're accountable within the public administration system. Again, also with providers, what is their nature? Again, are these in the UK? There was a transition to autonomous NHS, National Health System hospitals initially, because family practitioners or general practitioners are independent contractors anyway. But the providers, hospital providers, were state entities, but they transitioned to becoming autonomous providers. Why is that important? Because they need some flexibility. They also need to be able to enter into agreements. One very interesting regulatory challenge emerged early on, in that public sector entities are not allowed to contract with each other. So you can't use contract as an instrument, but one could use service agreements. So there was so much debate on what kind of instrument one could use in order to establish these the relationships between purchasers and providers. And of course, the regulatory framework also needs to define the extent of competition. And Jack will remember in the early 1990s, there were lots of debates about managed competition or managed markets. So all these terms that were being used, because or even regulated competition. This sounds like an oxymoron, but various terms were used to signal that there was no pure competition, because we know from Kenneth Arrow and others that pure competition fails, but we also know that purely regulated systems also become very rigid and do not function very well. So there was this attempt to move to a so-called the third way, as spoken in public management language. So one has to define within this regulatory framework, what is the extent of competition? And again, within the regulatory framework, one has to define what are the instruments that are going to be used to enter into relationships. Are these contracts? Are these service agreements? Again, this will vary from country to country. Fourth, in relation to regulation, is what is the currency for contracting? Is one contracting using, for example, a volume-based contracts? So for a given year, provider X provides services to a select catchment area or population. Or does one use other instruments, other currencies, such as bundled services, and there are various forms of these. For example, in the UK, health-related groups were developed, similar to diagnosis-related groups. Or does one use fee-for-service? Or does one use specific targeted volume-based contracts for specialties, with or without the performance-related pay? So that currency needs to be defined. And again, these didn't exist. And of course, and again, very important for purchasers to understand what is in and what's out. Is there an essential package that is going to be purchased? Or is there some flexibility at the margin or some discretion that purchasers have to purchase services that might be beyond what might be deemed as healthcare, for example, social services? Again, the boundaries need to be defined. Sixth, a very important issue is understanding performance. So benchmarking. How do we benchmark? There needs to be systems in place to have common costing approaches. In fact, the NHS published, I still remember the document, actually. It was called Costing for Contracting. this was really to provide, and it set out what providers should do to cost their services. And even then, the costing approaches varied. So this was an attempt to create a common platform and common approach to costing services. But even then, I remember there was huge variation in costs for a given outcome, for example, or for a given output. For example, for cataract surgery, just to give you a very simple example, simple in the sense that, cataract surgery is very straightforward. It's not like cardiac surgery or heart transplants, or managing mental illness over 1 year, which is a very complex multi-sectoral process. I remember I was purchasing from 33 different providers, my services. And for cataracts, I had prices, and the prices just in London varied sixfold. And they couldn't explain to me why there was a variation, that using exactly the same procedure, exactly the same materials, there was sixfold variation. So again, very important to benchmark costs and also outcomes or outputs to really understand what should be acceptable and what is not. Of course, once we benchmark and we enter into agreements, there's the issue of underperformance or overperformance. So the regulations, this is my sort of seventh point, regulations need to provide for managing underperformance. How will the provider units that underperform against a contract managed? Does this go to courts? Is there an independent arbitration panel? Or is this just negotiation to settle things? Again, regulations need to define that. But in some cases, there may also be a need for changing the management of these providers because they're consistent or persistent underperformance. So there needs to be regulatory provision for that. Or at an extreme, there could be mergers, or even there needs to be an exit scheme. Again, I'm using the word exit. It's a euphemistic term that was used at the time. It's really closing down these underperforming units that are not generating value. In fact, that might be even harming patients. So there needs to be a scheme for managing underperformance. But there needs to be considerations for overperformance. Because what happened in many, with some providers is that where the contracts did not specify a ceiling in the volume of services that were purchased, they became very efficient. So they were providing, I remember one provider in Oxford, within the first 6 months, they were able to provide all the contracted services, but they continued to provide services. But the purchasers didn't have the funds. But the contracts did not stipulate that there was a limit. And then what do these providers use when they become very super efficient and meet the contractual obligations? So there needs to be a system of management underperformance. And finally, in the UK context, there was a lot of discussion around what is the role of the purchaser, because this can range from being a passive payer, really a very transactional role, to becoming an active purchaser, as Inko was saying, in order to create better value, to improve productivity, for example, to ensure efficiency gains while improving outcomes. Or in the UK, we landed on the term commissioning, which actually was very difficult to explain to colleagues around the world what that actually meant. Essentially, it meant that purchasers could be strategic shapers of the health system. So they could use the purchasing as a function to modify not just the content of services to improve, not just to improve efficiency and effectiveness, but actually to modify the content of services and encourage optimization of the system as a whole. But it took a long time for these entities and for all of these regulatory provisions to come into force, and for purchasers to develop full purchasing capacity. And for many providers, they were really not ready to become providers, to enter into contracts. So it was a long journey. And then, plus échange, as they say, we find ourselves almost 30 plus years later. There is not a transition to integrated units. But I think I want to say this with a caveat, in that integration is happening between health and social sectors, whereas the purchaser-provider split was within the health sector. So I think it's very healthy to move to integrated models, but then that service agreement model will probably remain. But then we'll see what the new administration will do. Now let's come to Turkey, which again is a very interesting case study, and I'll be very brief. So prior to the health transformation program, Turkey had 5 parallel systems essentially. So there was a scheme for blue collar workers. Then there was a scheme for civil servants. There was an insurance scheme for retired civil servants. Then was an insurance scheme for artisans and small businesses and seasonal workers. Then there was a non-contributory scheme, so-called the green card scheme, which didn't function at all. Now, with the reforms, and then the Ministry of Health managed a set of Ministry of Health hospitals, and the Social Security Organization had its own provisions. So it was a very fragmented and confusing system with variable levels of benefits among the various schemes. So what the government did in order to create this purchaser-provider split was unified all the insurance schemes into a single social insurance organization that acts as a purchaser and a payer to and can purchase services from the private sector, from public sector, from government hospitals, but also from university hospitals that come actually under the purview of Ministry of Education, plus foundation hospitals that have a different purview. Plus the Ministry of Health oversees the performance of the public providers, also having integrated the Social Security Organization providers with Ministry of Health providers. They oversee performance, but they don't have a purchasing function. Ministry of Health performs a policy function. Now, that transition had brought greater transparency on what was being paid, but also allowed for the purchasing organization to introduce some instruments to improve efficiency, and also revolving funds to create incentives to improve productivity that could be used then to support salaries of health workers. And that scheme is functioning well. It has helped to improve efficiency, but it's not been, I've not seen data in relation to what has happened to improvement in effectiveness of care in relation to outcomes. So this is why this benchmarking and transparency is so important, because we need to know what is being achieved with this change in the organization of the system. So I'll stop there. So thank you for the opportunity, Nachiket.
No, thank you, Dr. Atun. This was very valuable, particularly the way you laid out the whole UK experience and what were some of the challenges that went through making this happen. And what you're saying is that in both examples, UK and Turkey, overall, the experience has been forward. You wouldn't say necessarily better, but the system has moved forward. And the integration that people are talking about is really more horizontal between the healthcare sector and the social sector. But the underlying NHS trust structure continues. And we hope to see what comes out of it.
Yeah, I think just very briefly, I think it's very important. You're right, absolutely right. Systems did move forward because we had greater transparency on how the money flowed and how they link to services, which is very important. So who's doing what and what is happening as a result. So I think that is very important. So we can better understand efficiency, effectiveness, equity and responsiveness of the services provided. So that is extremely valuable.
Right. No, thank you very much. Before I turn to Dr. Langenberner, I thought maybe I'll turn to you, Dr. Furtado, to take us through some of the ideas from an Indian perspective. We had, to just tell the audience, we had hoped to get Dr. Shankar Prinja to join us from PGI Chandigarh. He's one of the foremost experts in India on health economics issues. And he also had the opportunity for a while to be the executive director of the National Health Authority. He has a new paper on responsive financing, which I had hoped he would present here. But, Ministry of Health required him urgently to come for a meeting. And so, unfortunately, we don't have him here. But Dr. Furtado, who's a professor at the Goa Institute of Management and really has a PhD and experience in the whole issue of health financing, health systems. She's also a member of the Lancet Health Commission, a part of the core author team that is actually writing the report. I requested her to summarize some of the ideas from his paper so that we have a sense of what he is saying about this idea of responsive financing. Over to you, Dr. Furtado.
Thanks, Nachiket. So, hi everyone, and I'm just here in my capacity as a fellow on the commission to share some of the ideas that Dr. Prinja would have, we hoped would share from his work. And this is really, his work really serves as an illustration of the application of some of the things we've been talking about, that the panelists have been talking about in terms of strategic purchasing. So not so much about the split, but really moving from passive forms of purchasing to more strategic approaches. And he applies this to the financing of district hospitals in India. And I'm sure, most of you know, district hospitals in India are really meant to serve as the backbone of secondary level public healthcare delivery. So they're meant to provide comprehensive specialist care in a district. But due to the absence of gatekeeping, district hospitals also address a substantial portion of primary level healthcare services as well. So a lot of the outpatient care, primary level, also takes place in a district hospital. And so these are really important points of care within the public system. And so what Dr. Prinja and some senior experts in financing have really demonstrated is, can we develop a model for a more responsive financing method for these hospitals that is really more responsive to output, outcomes, and healthcare needs of the populations that they serve. So the current system of financing these hospitals is through the allocation of funds based on historical budgets, and they don't really consider actual utilization or healthcare needs. So the authors cite global evidence that we've also been talking about that favors really reformed payment methods, which are blended in nature. So, Dr. Matheo also mentioned, the individual payment methods all come with some limitation or the other. As we know, the fee-for-service and even DRGs, these really incentivize providers to increase outputs and volumes, but not really to contain costs unless they're applied within a framework of, say, hard budgets, etc., or regulation. On the other hand, we have things like capitation and global budgets, which have very strong cost containment incentives, but they could impact quality and productivity. And so what Dr. Prinja and colleagues really propose is a new blended payment framework that really combines some of these methods and addresses the limitations of the current passive supply-side financing system and moves towards a more strategic form of purchasing in line with global practices. They draw on the examples of the different countries that have adopted these payment systems, some of which have been mentioned earlier by the panelists, and they argue that there is enough evidence to show that these payment methods will improve equity and efficiency primarily, but also accessibility and affordability of healthcare services. So I'll just quickly talk about the model that they propose and some of the main impacts of the model that they've tested. So this blended payment model incorporates 3 types of payment methods. The first is for outpatient care. So for outpatient care, they suggest risk-adjusted global budgets. And they risk adjust these global budgets for certain parameters, which they find empirically to be positively associated with healthcare needs and resource requirements. So they analyze a bunch of supply and demand side factors to look at what really influences the healthcare resource requirement in a district hospital. And they find that the city tier, whether the district hospital is in a tier 1, 2, or 3 city, matters, and so tier 2 and tier 3 cities have lower costs. So this is one variable that is used to adjust the payment rate. The size of the hospital, which is dependent on the bed strength, and they use the infant mortality rate as a proxy indicator of healthcare status and therefore population health needs. So they argue that, of course, if we had better data on district healthcare status, that would be ideal. But until we get there, infant mortality is available at the district level and serves well to reflect population healthcare needs. Higher the infant mortality, higher is the service delivery need for that particular district hospital. So these are your adjustment factors. That's for outpatient care. For inpatient care, they suggest case-based bundled payments. This, a lot of us, as we know, is already being used for PMJ. And so they use costing data from the PMJ health benefits packages to come up with these estimates for what the case-based bundle payments should be for inpatient care. And all of this data is based on bottom-up costing methods that they've done across 27 hospitals in India. It's a robust methodology. I won't get into that. And the third part of the payment model is for indirect services, so administrative and ancillary services. So for this, they suggest global budgets based on the bed strength. So basically, the blended payment model for district hospitals has a risk-adjusted global budget for outpatient care, a case-based bundle payment for inpatient care, and the global budget for indirect services. And so using this model, they then look at the impact of how this revised blended payment model would really impact the budget for a district hospital. And they find that the average cost or the average annual budget for a district hospital is estimated at about 326 million rupees. And so, if you look at this now, this is the average. And of course, there's huge variation. As we know, the districts in India show huge variation. And as expected, they find huge variation in these estimates from about, 66 million rupees to 2.57 billion rupees. And this really gives you a sense that if you're using output-based costing and payment methods, you are going to get these sorts of variations in the budgets across district hospitals. Now, what's interesting is that they compare this to, what's the current budget for a district hospital anyway. And what they see is that this is not a much higher estimate than what is currently being paid to a district hospital. So in terms of impact, moving to this method of payment doesn't significantly increase the overall national payout to district hospitals. But what it does do is to more equitably distribute that budget within a state, based on the needs of different districts and hospitals. And so it really, aims to redistribute existing funds more efficiently, ensuring that resources are allocated based on specific healthcare needs of the population and the service delivery requirements of each hospital. So, it basically, the authors encourage policymakers to adopt these methods because through this, they can address the challenges faced in resource-constrained settings where they can effectively allocate resources to greater areas of greatest need and promote the optimal utilization of the resources that they have. Interestingly, they also do a one-on-one comparison in all the district hospitals of Tamil Nadu. And it's interesting to see that for some hospitals in Tamil Nadu, the revised payment models requires a higher amount than what's actually being paid. So they do say that, if you budget according to need, you can see that some district hospitals are currently being underpaid based on their requirements. And so this is also an important finding, especially since it's done in Tamil Nadu, which is usually a well-managed state in terms of its public sector, but could still do with a better means of allocating its available funds. Of course, the limitations are also highlighted, things that need to be kept in mind. About transitioning to these types of methods, and this is, of course, things like complex regulatory requirements or the reorganization that might be required within the public system, the resistance, of course, from stakeholders to move to these responsive payment methods, and budgetary constraints, as in some places, if they require higher budgetary requirement. But what they do suggest is that this has to be done in a careful, phased manner. It could also be that some hospitals continue with existing channels, because district hospitals receive money from different routes. So there are treasury routes and non-treasury routes. And so, one needs to consider these things. You might want to stick to centralized procurement for things like drugs and medicines, because that is an efficient way of doing that procurement, but you might want to move other things towards more responsive methods. So they do take cognizance of all of these things, but they say the most important thing is a regular systematic evaluation that accompanies the rollout of such a method, and really to look for what are the incentives and disincentives that might be brought into the system, for those implementing these mechanisms in terms of quality, access, cost effectiveness, and patient outcomes. And by looking at what these incentives and disincentives are, any unintended consequences or areas requiring adjustment can be identified promptly. So I think this is really, in a nutshell, what the paper really argues, that it suggests a very implementable framework. It proves that which consists of blended payment methods that are more strategically designed. It sees that it doesn't have a big impact on budgetary requirements, but rather allows states to more equitably distribute their resources between different districts based on need. And it also suggests these cautionary mechanisms of how to really roll out a strategic purchasing initiative like this one, over in the years to come. So yeah, I think that's about it, Nachiket.
No, thank you very much, Dr. Fataru. That was a wonderful summary of a complex set of ideas from Dr. Prinja. And I think it adds a lot of value to this discussion, coming particularly from somebody who understands the local system extremely well. Let me now turn to Dr. Langenbrunner to move this conversation along. Dr. Langenbrunner is a global health financing reform expert with 35 years of experience of advising governments on health systems reform, both in the developing world, but also within the US. He was formerly the lead health economist at the World Bank, where he led the design, development, and implementation of health sector projects, and was the resident technical advisor in China and Russia, and subsequently in Indonesia. He's currently an expert advisor on health systems reform in the Kingdom of Bahrain, and on social health insurance for the government of Indonesia. Dr. Langenbrunner, you've heard discussions now from interventions from three perspectives. The sense I have from listening to all of them is that, particularly from, if you start with Dr. Mathur, her perspective was, there are certainly some things that come along in terms of benefit of a purchaser-provider split, but you have to go through with the spirit of the reform. You can't simply execute the purchaser-provider split. I really was quite struck by an Egyptian example in which you did all the technical work, but you didn't actually go all the way forward and give the autonomy that was needed to improve performance. Simply going with this idea that you have a split will produce the results, is not, something that she supported. But I read from her remarks that even though explicit, if you were to say where are the results from this reform? Did health systems improve? Outcomes improve? That's been hard to prove. But the fact is that that movement has carried on across countries, and many countries are experimenting with this idea because there are many benefits that come from it, even if we can't prove the health outcomes. From Dr. Atun, we heard the experience of the UK, where, in a sense, the reform was a kind of a nuclear shift from one direction to another direction. Didn't do all the detailed work that was needed to make something like this happen. But over a 30-40 year period, many of these details got worked out. And he gave the example towards the end of Turkey, which really has seen some of the cleaning up, as it were, of the fragmentation and all of that coming up. What was interesting about Dr. Prinja's work, was that there was no split that he suggested. In fact, I thought he was building, even though he was not here, on Dr. Mathau's ideas to say, well, even without the split, if I can get the spirit of the reform in place, if I can get the autonomy, if I can get the risk adjustment, even without the split, I can actually make something like this happen. The question is, of course, without the split, the entity that is responsible for delivering the service, will they have the willingness to make the changes that are required? Because sometimes without the split, you don't get the independence. Now, I'm just summarizing for you some of these perspectives, but obviously, you know a great deal about what is going on in this. You worked with global systems, but we've had the good fortune of you having engaged with us in India actually quite a bit for the last several years. And while you were at the Gates Foundation, you then collaborated with the Niti Aayog team to put together a report in which you looked at the whole issue quite carefully, and at the end recommended this idea of thinking about strategic purchasing, moving away from line item budgets as a direction that we should pursue. I was just keen for you to reflect on what the others have said, but also, from your own perspective, both what has happened globally, but, really taking an India view as to what you think, knowing what you know about us. Is this a direction you would recommend to us? Are there issues that we should be cautious about? If you were sitting in our place in the commission, is this a reform that you would, endorse very strongly for us? I know it's a tall ask for you, Dr. Langenbrunner, but love to hear from you what you think.
Thank you for the opportunity to join you today, Dr. Moore. It's a very important and somewhat provocative question. I don't know how many hours you're going to give me to answer these questions, but nevertheless, I'll do my best. And it's really an honor to be sitting with such an impressive group of experts today. And I must say, I've learned a lot just sitting here in the last hour listening to the group of experts. So like Professor Atun, I want to start with a story, a true story in my case. I once worked with the Ministry of Finance in my own country, the United States, and I liked line items. They were easy to develop. You took last year's numbers, you updated them for inflation or some measure of fiscal space. They were easy to monitor in terms of how the sector was spending. So from my perspective in the Ministry of Finance, I like the line items very much. But then fast forward to 2016, 2017, pre-COVID in India, meeting with the Ministry of Finance team in India, we were looking for ways to invest in the sector. But the response from the Ministry of Finance team was, well, the health sector and the budget, they don't spend it well, and they send it back at the end of the year. And, with that, they sort of said, it's a good reason not to spend more on health in India. So, they were right. They were right on their first point, poor spending, and they were right on their second point. They were sending it back at the end of the year. But sadly, this meant they were not concerned about spending higher levels of health. And I think this continues to be a challenge in India. And a big part of the reason was really due to the fact that these Ministry of Finance rules and designs around line item budgets constrained the way money could be spent, and it constrained the way a full budget could be spent. And I have to say, I found India to be a kind of a world famous example, if you will, in a bad way, sadly, for its hundreds of line items in the health sector that I saw. pre-COVID. Now, I know that they are moving forward and with reforms, and I'm delighted to hear about that. Let me get to that later. But I also have to say that ironically, this concept originated with the British and the French overlords, the people who were in India previous, the British, and so I think we need to look at this both from a historic standpoint, but also what works today. And I would say that line items have at least three challenges, right? It's this lack of flexibility. There are line item multiple inputs for pharmacies, for pharmaceuticals, for salaries, for food, for supplies, for capital. But these can only be spent on these named items and areas. That works in education. You can predict the number of students. You can predict the number of books. You can predict the number of chairs, desks, school buildings. But you can't do that in health. You can't predict the need or demand, however you want to call it, however you want to measure it. You can't predict what's going to happen the next day at a clinic or a district hospital in terms of the people who come in and what they need. COVID was a very sad and recent example. It was an extraordinary example, but nevertheless, it gives us some sense that it's very difficult to predict how much is going to be needed across these various categories. And at the end of the year, if you did not spend it all, it's going to go back to the Ministry of Finance. The second sort of failure of line items is what's been talked about in various ways through the seminar is this public and private situation. So no private provider is going to accept line items. And I like the fact that PMJY has brought in the private sector. I know that you originally have started the seminar talking about public to public, but nevertheless, if you look at most countries in the world, they have brought in the private sector to some extent, and they will need to integrate the private sector, I believe, into India. They've done a good job so far in terms of PMJY and bringing in the private sector for hospitals, but I think the primary care sector remains, and that is a challenge. And I would like to see that come, not only because, as someone said, people vote with their feet, people want to go to the private sector. I can remember my days in Orissa when some of the people from the Department of Health said they take their children to the private sector. They don't take them to the public sector. They prefer the private sector. And we know that some of the best innovations globally come from the private sector, either in terms of provision or organization, pharmaceuticals, whatever. Finally, my third concern with line items is that they really don't align with the provider's interest. Indeed, their commitment to provide the highest quality care with the best outcome. We talked about the principal agent situation. Physicians are agents on behalf of the consumer, on behalf of the patient and their families. And doctors don't want to be constrained by these inputs to deliver the best quality, the best outcomes. And they don't want to be told that they have these economic firewalls about what they can spend when it comes to determining a patient's life. So those are three reasons I would say that we need to move beyond line item budgets in India. Going back to the Minister of Finance in India, and the money being sent back. I know that before COVID, Rajesh Jha and Manjari Baywalker looked at this issue of sending it back. And they found that the poorest states, Uttar Pradesh, Bihar, sent back almost 30% of their line item budgets, due to the late arrival of the transfer of funds, due to capacity issues on how to spend it, and things like that. So ironically, or sadly then, it was really the poorest who were suffering the most under this line item approach. So, I think there's a lot of good stories. Former Soviet Union went from 24 line items to 4, where they were being paid, they were using capital, utilities, salaries, and everything else. So it gave them much more flexibility, and they moved in many of those post-Soviet countries to greater autonomy. I mentioned that India is doing great. They are moving their hundreds of line items now to a smaller number. This is great. I think South Africa is an interesting example where they've moved their line items from inputs more towards outputs and programs. And I think that Inky can probably tell us a bit more, but there are some good things on the WHO website in terms of using line items, if you must use line items, and moving them more from inputs to more outputs and program-based services. But of course, to me, and the emergence of low and middle income countries, I think the purchaser-provider split is a much better way to go. The introduction of strategic purchasing, and again, the National Health Authority and the PMJY model have really started some new approaches, some innovative contracting approaches, some new payment models, some new quality and accountability model measures have been initiated. And yes, more needs to be done. I appreciated Dr. Prinja's presentation paper that was given here. I think he's on the right track. He's done a lot of good work so far, and I think he's on the right track. Yes, there's more to be done in terms of those bundled payments for inpatient care. But nevertheless, I think India is moving in the right direction, and I think their costing studies have really given them a good basis for making the next moves. So let me also talk about, in the last minute or so, some of the things that I've seen in your neighborhood. So I think Thailand is the most advanced model, where they have moved from line items under their universal coverage scheme to something where they have a line item for salaries, they have a line item for capital, but everything else is paid through the purchaser-provider split arrangement using some variant of DRGs, of diagnostic-related groups. And I think that's worth having a separate seminar just on the Thai model in terms of what they do, because they do mostly, I think 80% of their contracting is with the public sector. But I would also say that there's a very interesting article that came out just within the last year by Marshall and colleagues, showing that they have also now moved very aggressively to contracting with the private sector hospitals and private sector clinics, especially in Bangkok, where people seem to prefer using the private sector. But nevertheless, overall, nationally, the Thai and the Universal Coverage Scheme do contract with about 80% of their money do go to the public sector. If you look at Indonesia, very interesting model. They went from hundreds, 5 big schemes and hundreds of smaller district schemes to one single payer model back in 2014. And they also opened it up to the private sector. And about 50% of the people there have joined, they have signed up with a private clinic. Nevertheless, they could also go to a public or private hospital if they were referred up. Now, that's the sort of good part, but at the same time, there have been some issues in Indonesia, similar to what we see in Philippines, for example, and that is, while they say they have a single payer model, only about 30%, well, even less than 30%, I would say about 25% of their of their health sector spending is actually going through the single payer purchaser. So they are still allocating another 30% through fiscal transfers, through the Ministry of Health to their districts, to about 520 districts. And these are through line items. And what they have found that so if you are a public PHC provider in Indonesia, you get some of your money through these line items, and you get some of your money through your capitation payment through the purchaser in the single payer purchaser. So that creates a problem, because providers are then faced with multiple rules, right? Multiple rules. They are being given greater autonomy. There is some regulation for greater autonomy, so they're being given greater autonomy, but they are still stuck with various rules and regulations across their various line items. And so they have, in the last year, under the new minister, have recognized this issue, and they have said, let's look at this. Let's look at a way to go to greater pooling, maybe virtual pooling. And so they have started their study, and they have found, not surprisingly, that no one is spending their line item budgets. Something between 70 and 95% of their line items are being spent, and the rest are being sent back to the Ministry of Finance. And again, as in India, as with the Jha and Baywalker findings, it's the poorest districts who are sending back the most. It's the poorest districts that are sending back the most because, again, it seems to be a capacity issue. It seems to be a capacity issue in terms of, well, here's our rules and regulations. Now, how do we actually use them? How can we use our money most effectively, and how can we spend the most? So I think that we see these patterns are very similar across countries when there is sort of this situation of either line items, or in the case of Philippines and in Indonesia, sort of this halfway reform, where some of the money is now being sent through the purchaser-provider split arrangement, and some of the money remains being sent through these line item transfers. So let me stop there, Dr. Moore, and turn it back to you. I'm sure we have a lot of questions, but thank you again. Over to you.
Right. No, and in fact, what you described, Dr. Langenbrunner, is exactly what we are seeing in India now with PMJY, because government hospitals are receiving some money from PMJY and a lot of the money from the line item budgets. And I worry what is going on there, because the language I'm hearing from the government hospitals is earlier what was free is now contingent upon, will I get PMJY benefits or not? And in a way, instead of increasing inclusion, I worry it might be increasing exclusion, because now if you're not eligible for PMJY, the government hospital will not treat you because they will not get the additional monies that they were getting earlier. We don't have a lot of time, but I want to turn back to Dr. Mathur. Some of the questions we are getting, and it's something that, one way or the other as a commission, we have to debate on. One is something that you clarified to me, which is, let us assume that at least at the reform level, the intent we are able to get to go all the way, to do the split and to do all the things that follow the split that you pointed out, that Dr. Atun pointed out, that need to come with it. This idea of how do you deal with underperformance? How do you deal with overperformance? What is the detail that's going to accompany this? Would you say that would be a good direction for us to be thinking about as a nation embarking on a reform method? Because one of the challenges we are facing in India is that, at least in my view, the public sector is not being given the room to do all it can. The presumption is that people prefer the private sector, but our consumer surveys are not showing us that. They are showing us as greater trust in the public sector. But unfortunately, the public sector is not able to perform the functions that it is. And what we are hoping, at least in the commission, is to use some of these instruments to free up the energy of the public sector provider, to say to the public sector provider, we trust you. We know that you know what you are doing. Through these line items, maybe we constrained you in ways that were inappropriate, but now we are allowing you to show what's going on. What would be your sense, Dr. Mathur? You've seen so many countries, both rich and poor, about the direction we should go. We don't have a lot of time, unfortunately, but I thought maybe I'll give you the last word to bring some of this discussion to some of the questions that we are grappling with. Over to you, Dr. Mathur.
Yeah, thank you. Thanks so much for this really interesting and important question. And again, thanks for this super discussion, listening to the panel. I mean, let me approach it from 2 points. One is there is already the experience with PMJ and the specific state agencies, as they're called, differently across the states. But there is this model already. And so this is something to build upon. And I think Jack was also referring to that. So this is from the purchaser provider side. The implicit or the contractual relationships are set up. And it's currently primarily only looking at secondary care being funded through PMJ, but this is sort of the entry point. So from that point of view, I would definitely say this is the direction to go. Now, I haven't lived myself and worked directly for a longer time in India, so this is a very sort of a distant perspective, but to me, this makes absolute sense. Now, coming back to your second point, which is about the provider side, the public sector. The trust, of course, is an important issue, although we have to see, I mean, you know, where do people at the end go? But I just would like to bring up the example of Karnataka that has introduced this, what they call online referral system, ORS. It's basically a digital referral system, which has allowed to really enforce the referral rules. The idea was to, or is, to actually strengthen capacity of the public sector hospitals. And by shifting more patients who are being referred to the public sector. And I think the experience there shows, in fact, that if you give more resources to the public sector, and if patients are initially forced, in quotation marks, through the referral rules to go there, then there is this capacity expansion. And of course, it takes time also for people to get convinced. But I think this is what we see. This is something very concrete, I know, from Karnataka, because we have looked at this aspect from the digital technology perspective. But I think it relates to what you were saying. So, yep, I think these are my initial quick thoughts on that. Over, thanks.
So thank you very much. We are almost out of time. So I'm just going to quickly bring, yes, Dr. Atul, please.
Just a very quick intervention to add to what Jack was saying in terms of line item budget, 3 limitations. There's a fourth one in that these budgets tend to be historic. So they reflect history. They don't reflect the current and future needs. And and looking at the questions, certainly this is the direction forward. I have no doubt, because one of the very important benefits is providing the flexibility in using this budget to invest in areas where there's current and there might be future need. But very importantly, the purchaser provider split, what it did do in England was to empower primary care. We're able to shift many services from hospital to primary and community level and invest very substantially in underserved areas such as mental illness. And I think this provides the great opportunity to harness those benefits as you transition from a very rigid administrative instrument, which is the line item historic budgeting.
No, thank you very much. I take away from this rich discussion, and we will, of course, prepare minutes and go through the recording very carefully to make sure we inform the Commission about what transpired. But a sense that, you know, the current system as it stands, there are a number of challenges. And while, you know, the new direction that we are talking about, or new to us in India, you know, does have challenges of its own. It's not that it's a magic bullet that you press the button and it gets done. There's clearly some benefits that come with it. And the sense I get from the panel is that it's something that they would believe we should be considering. The second thing that I get a sense from people who have looked at India, both Dr. Mathur and Dr. Langenbrunner, as well as Dr. Prinja's paper, we don't have the benefit of his presence here. There is a lot going on in India. We should not assume that this is an entirely new idea we're bringing in from Turkey or from UK into India. There is the PMJY that has had some success. I really like Dr. Mathur's example of what Karnataka is doing, because what she's saying is that maybe initially it feels somewhat counterintuitive that you are forcing people to go in a direction they might not otherwise. But actually, once they go there and the resources are given to the public sector, they are indeed able to provide the service. I do hear Dr. Langenbrunner say, and I've also heard something similar from Viroj, which in a sense he's reflecting some of the experiences that Thailand is going through right now, is that involving the private sector may be an important thing, but it's something Dr. Mathau pointed out earlier. There may not be a private sector in many places that we are thinking about. One of the reasons why PMJY is unable to get traction in states like Chhattisgarh, for example, UP or Bihar, is there are no hospitals. And indeed, it may come to the public sector setting these up because, as Dr. Atun pointed out, the underserved areas, both geographically as well as disease-specific wise, using these models actually allow us to be strategic in allocating money rather than historical. We may have started historically in a certain direction, but now we have an opportunity to redo this in a much more strategic manner and bring the benefits of the two together. So I really want to thank the panelists for their time and for really sharing with us this extremely valuable insights for this. I'm unfortunately, we don't have enough time for a full debate on all these issues. As Dr. Langenbrunner said, it will need several hours for us to do it, which we do not right now have. But I think we've gained a lot from this discussion, and we hope to incorporate some of these ideas as we deliberate further in the commission as to what is the recommendation we want to make. Thank you all. Shubhangi, was there something else we needed to do, or can we close the discussion at this point?
I think we can. Thank you so much, Nachiket and everyone.
Thank you very much. And
Thank
have
you.
a
Thank you for all of
good
you.
night and good morning. Thank you.
Thank you.
Thanks.
Bye-bye.
Bye-bye.
Bye.